understand these diagnostic tests, some of them have a long turnaround time. That is, from your sample to report, it takes about sometimes 6 to 8 weeks. So this is about 2 months. Doesn't the patient who's been diagnosed or who's even come to you at a later point when the chemotherapy failed, is 6 weeks not a very long time? Will the cancer not start behaving uglier in that waiting period? Genomic testing is a complex science. Interpretation is an art. To understand more about this, today we have Dr. Amit Verma with us for the session. So, Dr. Amit Verma is founder and director of Dr. A.V. Institute of Personalized Cancer Therapy. He is a molecular oncologist as well as a clinical geneticist with about 15 years of experience. He believes in the contemporary cancer treatment, that is precision oncology. So, we would like to know more about somatic analysis from you in today's session. So,
Thank you, Payal. So, somatic analysis, the word soma stands for the tumor cells, and anything to or on the tumor cells is called somatic analysis. Especially, either it can be used for diagnosis or it can be used for prognosis. Prognosis. So, they are two important things, and it can also be used for prediction. So, the third category. So, diagnosis, prognosis, and prediction. So, we have various ways to do the somatic analysis. It can start with the protein expression, which is can be done by basic simple immunohistochemistry, or it can be, or we can use some technologies where we do just the histology, which is called the HNE staining, which is again under the microscope. These are the basic tests, and then we have some special stains to identify what types of expression does the tissue has or the tumor has, and then we take it to the next level, that is the at the chromosome level, where we look for the amplifications, fusions of the different chromosomes, and the technologies like FISH or ISH can be used to identify these kind of fusions. And then if you want to go a little further, which is on the closer look towards the chromosome, then we have at the level of DNA and the RNA, we have technologies like PCR, real-time PCR, or ddPCR, droplet digital PCRs, and then we have the Sanger sequencing, and then we have the next generation sequencing. So these are the technologies which can understand the DNA or the RNA better. Try to these technologies help us to understand the alterations, various types of alterations seen at this level.
Right. All right. So basically, when we talk about somatic analysis, we are essentially talking about solid cancer tumors.
So, somatic analysis is applicable to all cancer types, whether it's a liquid tumor like leukemias or lymphomas, or solid malignancies from head to toe, starting from brain tumor, head and neck cancers, thoracic cancers like lung cancers, GI cancers, GU cancers, bone tumors, sarcomas. This is a category what we call as solid tumors. Leukemias and lymphomas are called the liquid malignancies. So, analysis of a tumor cell, whether it is a liquid tumor or a solid tumor, is called somatic analysis.
Okay, all right. So, in solid cancers, what are the different types of sample types that are used for analysis?
So, let us talk about solid cancers. We have access to the information via the tumor biopsies. Sometimes, when the biopsies are difficult, we use the affinaces, which is called where we collect the cytology or the cells, make the cell block, and then go for the analysis. Sometimes we use technologies called fresh frozen samples, which is on the table to understand these things. And sometimes we use is the archived tissues in a paraffin embedded block, which can come from either the biopsy or the post surgical specimen. And also Somatic analysis can be carried out on technology called liquid biopsy, which is done either on the blood or in the urine or any bodily fluid where we expect that there is a leakage of the DNA in that particular fluid or the body fluid actually.
Yeah. So to emphasize, liquid biopsy is not for liquid malignancies. Liquid biopsies is for solid malignancies where the tumor tissue is unresectable or unavailable to take a biopsy.
Yes.
Interesting. So, is liquid biopsy one of the more upcoming or recent tests, or it has been available in the arena of testing from?
So liquid biopsy is one of the recent advancement based on the newer technologies available, which have the deep sequencing capabilities, where we can pick up the minute level of DNA and can multiply the alterations at multiple times so that we can see whether these alterations are true. So these technologies are definitely new, and so there's a new advancement in the diagnostic industry actually.
So, what are the different genetic tests available for somatic analysis?
Somatic analysis can be categorized into two important types. One is a single gene testing, and the other is multi gene testing. For single gene testing, or when we know what types of genes could be altered and what types of alterations are possible, when we know beforehand, especially in certain cancers, we tend to go for single gene testing. Um, in the scenarios when we are not very sure what genetic alterations would be there, what genes would be altered, we try to go for multi-gene testing. So multi-gene testing can be considered as an exploratory approach where we are not very sure what we're going to end up with. In multi-gene testing, we have again options of a smaller panel, a middle panel, or a medium panel, or a larger panel. There is no definition about this category, but approximately any gene testing which is in the range of 10 to 15 can be considered a smaller panel. Between 15 to 50 can be considered a medium-sized panel, and anything above 50 to 500 can be considered a larger panel.
Okay. So, which one to go for, single gene or multi gene, and how is that decision approached?
So, as I just said, that in certain scenarios when we are very sure that this is the key or gene which is the reason for the tumor genesis, we can straight away go ahead with the mutation of a single gene testing.
Okay.
Like in ovarian cancer, we are well aware that the BRCA1 and BRCA2 genes are the culprit for most of the ovarian cancer. So simple testing is very easy to go ahead. On the contrary, when like in lung cancer, when we are not very sure whether the patient is harboring EGFR mutation, ALK mutation, ROS mutation, MET mutation, ERB2 mutation, those different things needs to be addressed by the multi-gene testing.
All right. All right. So, a doctor decides which multi-gene testing, small, medium, or large, or a patient decides which testing would, would they like to go for?
So it's a very good question. Physicians are obligated to inform what is available in the market and what are the pros and cons of each investigation, especially in terms of what is the yield. So the physicians tend to offer a comprehensive panel more because you have the higher probability of hitting some targets actually. But at the same time, the cost is prohibitive as compared to the smaller gene panel. So sometimes patients' practical scenarios, financial constraints also take into account before we order the test. Interestingly, comprehensive panels sometimes are too complex for the physician to interpret also. So sometimes few physicians refrain to confuse themselves as well as the patient while discussing the options to go for this kind of test. They tend to go for a small panel which are simpler, easy to interpret and easy to follow. So there is no set guidelines in terms of should we go a smaller panel or a larger panel, but In certain cancers, few cancers like lung cancer, the guidelines do recommend to use a panel which includes at least important genes, which can be in the range of 8 to 9 important genes actually. But for other indications, this has not been well established. But in my clinical practice, and what we offer is a comprehensive genomic profiling for all of our patients. We do not want any options to be unturned. So all the stones should be turned, all the options should be looked around, and then we see what is the best for the patient.
Okay. So I've heard about this comprehensive genomic testing from you a couple of times. Can you elaborate what all what is comprehensive? Is it what all includes to make it comprehensive?
So the word comprehensive literally means end to end. So in the DNA, we have certain areas what we call as exons, which are expressed part of the genes, and then we have introns which are not expressed. But sometimes the alterations are sitting at the cusp of intron and exon, what we call as intron and exon boundaries. So when we do the analysis, a comprehensive analysis, this analysis or the coverage of the gene is end to end. All the exons are covered, all the introns and exon boundaries are covered of, of the gene. So let's say a gene is carrying 20 important exons, and then we have almost like um, 40 intron exon boundaries on
Right.
the 5 prime as well as 3 prime side. So this has to be covered. This is considered to be comprehensive. Comprehensive also means that all types of variants are covered, like the single nucleotide variant,
Okay.
the insertions and deletions type of variant, the copy number alterations, as well as the fusion or large rearrangements. So these are the four categories of alterations. So comprehensive is not only covering the complete gene for analysis, but also covering the types of variations while doing the analysis. So that is what the comprehensive stands for.
And what are the other outcomes that we receive
So
from?
once we do a sequencing on these kind of tumor samples and read so many genes together, we get plenty of information. And that plenty of information can give us genomic signatures like microsatellite instability signatures. It can also give us signatures what we call as tumor mutation burden and uh, information like loss of heterozygosity or the homologous recombination deficient score, or called what we call as HRD score. So these are the information what we get when we do a larger comprehensive panel of analysis on a larger genes actually.
So, basis of the somatic analysis outcomes, therapy is decided. So, I think the DNA and the RNA and the fusion part or the types of mutations was clear. Can you throw a little more light on what is microsatellite instability or loss of heterozygosity or tumor mutation burden, and how are those outcomes added or impacted on the decisions, treatment decisions?
Interesting. So um, the macrosatellite instability or tumor mutation burden or loss of heterozygosity. These are the key biomarkers for the genomic instability. So once we have a genomic instability, we have uh, understanding that the proteins which are being formed are altered as compared to the parent cell, that is the non-tumorous cell.
Okay.
And once the proteins are altered, we call them as new antigen.
Neoantigen.
New antigen. So the patients harboring new antigen tend to show more responses to immunotherapy. Patients who harbor the loss of heterozygosity, in especially in the genes which are involved in the DNA repair defect, are eligible for PARP inhibitors. So these are the genomic biomarkers which are very helpful. When we try to go little in detail, what does the TMB stands for? TMB stands for tumor mutation burden, which gives you a holistic view of the non-synonymous alterations, uh, mutations per megabase. So we read a big genome and see what types of alterations are present. Then we do our mathematical calculation and see if one megabase is having how many alterations. And that has to be relevant in terms of the functionality, implications in the protein change or the amino acid change. This is what is the tumor mutation talks about. Higher the tumor mutation burden reflects higher the genomic instability, better responses to drugs like immunotherapy. Similarly, microsatellite instability is an analysis where we try to see a single nucleotide and the dinucleotide repeats in the genomic sequences. Normally, our body have a mechanism what we call as mismatch repair mechanisms or a DNA repair mechanism, which corrects all these aberrant expressions or repeats if they are not as compared to the parent DNA. So if these MSI is unusually longer, we consider them as microsatellite instability, and this again reflects the genomic instability, which again is a biomarker for response to immunotherapy. And genomic information like loss of heterozygosity. For every particular gene, we have two alleles coming from one from the father side, one from the mother side. And if one DNA is altered and the normal DNA is lost, this is called loss of heterozygosity. So heterozygosity means if these two things are similar, this is called similarity or homozygosity. If this is altered, then this is a heterozygosity, and if this is lost, this is called loss of heterozygosity. So very simple concept. And if it is there, then the patient can be expected to respond to drugs like PARP inhibitors.
So, if I understanding this correct, by doing the analysis by sequencing, we are finding the cause of that led to this cancer, and these are kind of the effect that led to the genome because of of the cancer cells, the genome of the cancer cells, and we are clubbing both of this information that makes it a comprehensive outcome to make precision medicine decisions for patients.
So this genomic test give you information about the genomic signatures and the genomic mutations, and when we combine them together, it gives you a holistic picture uh, for the genomic alterations which are causing cancer and help us to identify the best treatment options. Among the options of treatment, we can find out the right target therapies. We can identify whether the patient is eligible for the immunotherapy for that matter. We can also understand uh, will the target therapy will work or not for these patients. So what we call as the secondary resistance mechanisms or primary resistance mechanisms. We can also decipher clues regarding the responses to chemotherapy as well in certain scenarios. So this is a very important information what we get when we do a comprehensive analysis for that matter.
Okay, so I mean, our discussion today is so that the patients understand about this better because when I hope not, but when one needs to deal with this, they are a little bit more aware of these jargons. But is a patient really required to know about these or understand what you are trying to do with his or her cancer?
Certainly. So, as a physicians, as a molecular oncologist, we are obliged to explain everything to the patient. And the reason being, it is a collective decision. It is not decision made by the physician per se, but a collective decision made by the patient family members also participate in the decision because this is a journey. Cancer treatment is a journey. It is not only a one shot what we have to try, but it has to go on for long. So everybody plays a role. Uh, it involves the financial aspect, it involves the social, the psychological, and from the treatment point of view, these treatments have a lot of toll on the body, especially the side effects possibilities, the complications, and definitely There are scenarios where the things can go in a direction where we cannot control. So we have to apprise of all the possibilities to the patient as well as the family members. So certainly it cannot be taken alone by the physician.
Okay. Any do's or don'ts that you suggest for a patient or their family members when it comes to approach towards precision oncology or somatic analysis testing?
So in terms of choices, we normally recommend the best in the industry, which are approved by the FDA, which gives a robust information, and we are relying on that. So this information is a very key information. We cannot say that this is a half-hearted results. So we have to rely on something which is acceptable to the physician across the globe. If somebody wants to take an opinion in India or abroad, the report should be useful for them as well. So please try to pick up a test which is approved by an authority where you can ascertain the quality. Then we have scenarios where the FDA approval is not there for many of the tests. Then the quality can be assured by the quality schemes what the laboratory follows, which we can inquire to the laboratory directly. This is the second approach. Then definitely a patient should discuss with the physician about their experiences with these reports. Are they comprehensive enough to help you in the past? Um, does this panel enough in this particular indication of for cancer, or do we need a larger panel for that matter? So all those deliberation has to happen with the physician before the decisions are taken actually into account. And also the timing of the test. The sample source is also very important. Depending upon the treatment lines and the time of the biopsy is very important. Let's assume for a minute that the patient is having fifth line of treatment, but the analysis is sent on the biopsy, which was treatment 9, then it is not going to help me that much. So we have to prefer a recent most biopsies which are feasible in practical terms. And whenever we do not have access to these biopsies, we can go with the technologies like liquid biopsy. So those kind of discussions and options should be discussed with the physicians and the patient together and come up with a plan. So this is something which I would like to recommend. Do not haste in taking those decisions. Patiently understand what are the benefits because there's a lot of cost involved in these tests, and we do not want to recommend the test again and again for practical reasons.
All right. So, Dr. Verma, I think this analysis in itself, I understand, builds up a lot of hope. Means I am assuming that a patient builds up hope that if they've come for precision oncology, if they've done an array of tests, there should be an outcome that may help them to next step. But sometimes we know that there's a no outcome report, means a negative report, that is no changes that can be utilized. It could be an outcome. And is it a good or a bad outcome?
So we try to look for targets or the genetic alteration with what we call as actionable target. Means that we did a test, we find a genetic alteration, and we have a drug for it. That is called actionable target. Or that alteration gives us some information in terms of prognosis or in terms of choosing the treatment. That is what we call as actionable target. But there are scenarios where we have the alterations and we do not have any drug for them. We call them as non-actionable, and it is very unfortunate scenario. We do have scenarios where the genetic alterations are lying outside the panel of genes what we have analyzed. In that case, the result seems to be blank, but cancer happens because of the genetic alterations. Absence of no alteration means that we have missed something. So this can be considered as false negative. On the other hand, finding some alteration for which we do not have a drug is quite a scenario. So, in practical terms, 1 in 5 patients will benefit of all these approaches. Actionable targets are normally seen in 4 out of 5 cases. So, this big gap is The reason of this big gap is when you say that we have 4 out of 5 patients having extremal target, but one of the 5 patients will benefit, we have practical scenarios coming in between, like drug accessibility. It may not be available in India. Drug toxicity, even if you start the drug, it may not be suitable for the patient. Sometimes alterations are there which can be multiple alterations in the given patients. So what we call as multiple driver alterations. And you are not practically comfortable to combine so many drugs together. So having said that, 1 in 5 patients what in our clinical experience truly benefit out of this approach. But 4 out of 5 patients do find something which are relevant for their own treatment decisions actually. So, yes, this is not a simple test, and as you rightly said in the first go, that this diagnostics test is a complex science, but interpretation is an art. So this is what we do in our clinical practice. We try to interpret for the patient, we try to interpret for the treating physicians, and we try to treat the patient accordingly based on the best genomic information what we have.
Okay, so since the chemistry of this science and art takes a lot of time, I understand these diagnostic tests. Some of them have a long turnaround time. That is, from your sample to report, it takes about sometimes 6 to 8 weeks. So this is about 2 months. Doesn't the patient who's been diagnosed or who's even come to you at a later point when the chemotherapy failed, is 6 weeks not a very long time? Will the cancer not start behaving uglier in that waiting period?
So, with the advent of technologies and the request what we receive these days now, the time has shortened from 4 to 6 weeks to practically 2 to 3 weeks now. So this has really shortened. Um, so in scenarios where the patient is critically ill, we do not delay the treatment. We try to go with
Okay.
the immediate treatment. If we find that the patient is stable enough to wait for a couple of weeks, we tend to wait because we want to be very sure before we start the treatment. Once the treatment is started, we do not want to change the treatment actually. So that is why we want to be right when we know what is the best for the patient. So we better wait if the patient is stable enough,
Okay.
and hope that the cancer does not spread that fast. But a waiting time for a week to 2 weeks is not that much detrimental as compared to giving the treatment which is not that worth working actually.
Right. So, the longer I speak to you, I understand it is one day at a time, one point at a time. As in, there is no straight answer for, uh, what could you expect next. What each report on each outcome will unravel the therapy decisions and the line on with which the patient walks through their cancer journey. But I can definitely say one thing. I think all of our in each of our families, there might be one closer or distant family with cancer, and the journey of cancer treatment, diagnosis and treatment is definitely not easy. But it is made the whole journey a little more intriguing with this variety of new tests and outcomes coming, which is aggressively changed since the last decade, and we keep hearing about more and more new tests. So, what next?
So we try to believe in the concept of making the cancer like a chronic disease, and this particular approach is truly making this happen. The cancer which have and had a dismal prognosis, in current scenario it is getting better. Patients who were living like in lung cancer, living approximately less than 6 months, are now on average lives approximately 5 years. So that kind of change happened just because of the precision oncology what we practice, and makes a huge difference for the patient. So I certainly believe that this technology, as it is going to advance further, and we have more and more options coming, the lifespan of the cancer patients will be longer. We will see more cancer survivors, and we'll see cancer being taken like a chronic disease like diabetes and hypertension. And I think this is the future actually. Yeah, this is the future. We are not suggesting that chemotherapy is going to be obsolete, but chemotherapy will be considered as later lines when everything fades. We want to offer them the right treatment at the right time for the right person.
All right. So I'm very keen to know that at Dr. AV Institute, uh, all of the following is available: diagnosis of these tests. Of course, like you said, you provide the interpretation and analysis, and also the patient can use this. Use your you have a daycare facility where targeted therapy can be given and home care facility, so you are actually covering the whole spectrum. So anything you'd like to tell about Dr. AB Institute and
Yeah, so our approach is a holistic approach in the precision oncology sphere. Besides the diagnosis, prognostic, and prediction, what we do on the testing part, we do a lot of interpretation in terms of finding the right treatment. We offer the precision oncology based treatment, which can be given in our daycare or at home for people who are living at the remote places.
okay.
We do handle a lot of complications related to the treatment, even at home, so that the patient gets a lot of benefit. Hospital or hospital environment primarily is a scenario where the patient who have low immunity, especially the cancer patient or immunocompromised patient, can have infections. So we try to avoid all those possibilities by giving the best care at home. Besides this, we are also offering a holistic approach towards the health in terms of meditation, yoga, physiotherapy, dietary support. Not many things we are trying to help the patient. Not only we are trying to treat the patient, we are also understanding why this cancer happened in the first place and identifying the cause. And if the cause is genetic, we try to help the family members who are unaffected family members to find them if they are also prone to develop these type of cancers. So we try to help them, the asymptomatic patients, for cancer screening. We try to prevent the cancer by certain ways, what we call as chemo prevention, or we offer them the surgeries like follicular surgeries. So it is a holistic approach towards the cancer. We want to make a big difference in the society. We want to offer our patients the precision oncology, and we believe that the precision oncology is the best way forward for cancer treatment.
Thank you very much for the patient explanation through the somatic analysis and what types of tests should be taken and why and why not. It has been a pleasure to have this discussion with you. Thank you, Dr. Amit.
Thank